Hello, ski patrollers. Will Vaughn here, EMS advisor for the New Jersey region of the National Ski Patrol and also a member of the National Winter Activity Center Ski Patrol. We last spoke during a previous refresher season about spinal motion restriction. At that time, I challenged some of your previously held beliefs about backboards and the risks and benefits of using them. Hopefully, I was able to make a good case for why the more modern approach of spinal motion restriction was valuable. In that case, we identified that the risks of using backboards in many cases were outweighing the benefits. And what we were looking to do was identify the specific subset of our patients that would benefit from a strategy of spinal motion restriction. So I'm back this year, and I ask you to suspend your disbelief because we're going to talk about another sacred cow, which is giving oxygen. You may ask, how on earth could giving oxygen be harmful? And you might also say, why do they keep taking things away from us that are potentially beneficial to the patients? And I'd like to make the argument to you that giving oxygen is still of benefit, but to a smaller subset of our patients. In reality, medicine has known for a very long time that giving too much oxygen to people is potentially harmful. At the cellular level, without going too far down the rabbit hole, flooding cells with oxygen, particularly cells that have been deprived of oxygen, causes oxygen-free radicals, which cause end organ damage. In EMS, they have specifically highlighted for us the role of this in heart attacks and strokes. Giving enormous amounts of oxygen to people who are not hypoxic results in the accumulation of these free radicals in the brain or in the heart, depending on whether it's a stroke or a heart attack, and potentially worsens the damage to those organs in those cases. And they continue to identify other cases within emergency medicine where this phenomenon exists. So going back historically, why on earth did we decide that every scenario would end with give the patient 15 liters per minute of oxygen by non-rebreather mask? And the answer is the 1994 EMT curriculum. In that revision, there was a decision made to kind of dumb things down, make them simpler and straightforward, and rather than having complex decisions to make about whether to give oxygen, in nearly every case of significant illness or injury, we were to give oxygen 15 liters per minute by a non-rebreather mask. Well, so why is this inappropriate? How on earth could this possibly harm someone? Well, our goal is not to over-oxygenate people. In fact, there are really only two scenarios that we teach within OEC where we would want to flood people with oxygen. And one would be a scuba diving injury where we're trying to wash out nitrogen from the tissues. And the other would be carbon monoxide poisoning, where we're trying to flood the blood with oxygen so that carbon monoxide will be decoupled from the hemoglobin that it's hanging onto. Aside from that, really what we're trying to do is fix hypoxia. If someone is lacking oxygen for whatever reason, whether it's a breathing problem or it's shock, we want to bring them back to a normal state of homeostasis. So, what does this mean for us practically? Well, I'll come back to this a couple times, but one thing is if somebody's fighting to breathe or if somebody is clearly in a state of shock, they're pale, cool, diaphoretic, they have a mechanism of injury suggestive of blood loss, we're probably going to continue to give them high flow oxygen via non-rebreather mask, certainly on the hill. However, that's not necessarily the majority of the patients that we have. We have a lot of patients that are in the kind of in-between category where we're not sure whether they're seriously injured or not. And we have patients who we might have given oxygen to in the past, for example, with an extremity fracture, who really don't benefit from supplemental oxygen. They don't need it. There's no issue with the amount of oxygen that's being carried by their blood. So we're introducing a tool that was in the OEC 5th edition, but is now something that's going to be highlighted going forward. And if you saw the National Medical Advisor's article in Ski Patrol magazine, which I would encourage you to read, it highlights the value of a pulse oximeter. So what does a pulse oximeter do? Well, a pulse oximeter measures the oxygen saturation of hemoglobin, how much oxygen is being carried by the hemoglobin in your red blood cells. And it does it with a fingertip device. And these devices used to be rather expensive, and now they're extraordinarily cheap. Actually, the circular for Aldi supermarket that came in the junk mail this week is advertising $20 for them. So they're a little more if you buy them through a medical supply house, but they've really come down in price, and the quality is quite good. In the past, we kind of dismissed this as a tool for us. With the rest of medicine and the rest of EMS really using these extensively, it's really not a tool we can afford to ignore. One thing to understand is that the use of a pulse oximeter it can be limited by the circulation in your fingers. So if it's extremely cold, you may not necessarily get an adequate reading on the hill, but it's not always freezing cold when we're skiing. And also EMS operates outside in other contexts, and we use pulse oximeters there as well. So it's still a tool that you'll want to deploy, and certainly a tool that you can use every time when the patient's indoors. So how does it work? Well, it's as simple as turning it on, putting it on the finger, and it'll give you a reading. You can see on here that there's a couple things. Right? We've got a pulse rate, we've got a saturation, and we've got what's called a pleth. So the pleth is showing the actual beat of my pulse. The heart rate is an electronic heart rate, and then the saturation is how much hemoglobin is bound, how much oxygen. So what are we looking for? Well, we're really looking for 94 to 99%. If it's less than 94, we would consider the patient to be hypoxic enough that they would benefit from some type of supplemental oxygen. And if it's 99%, we really don't need to give more. The scale ends at 100, so if you're giving oxygen by non-rebreather mask and it's at 100, it might be 100 or it might be 300. Actually, it depends, but you could really super oxygenate somebody and not know it. So 94 to 99 is generally our goal. Again, if we have an odd reading, or we're outside and we're not confident in what we're getting, or if the patient just looks super sick, then we give oxygen anyway. That's fine. But let's say somebody's got a head injury and they're outside and we're not sure exactly what's going on. Maybe they have a concussion, maybe it's more severe than that. We might give them 15 liters per minute of oxygen via non-rebreather mask and then bring them indoors, and when cooler heads prevail, we get a pulse oximeter on their finger, and we can actually titrate that oxygen to their need. Maybe we get inside, we take that oxygen off, right, and we see, patient's holding at 98, 99%. We don't need to give them any oxygen. Or maybe, the oxygen saturation's 91%, and we can give oxygen via nasal cannula as opposed to flooding them with oxygen by a non-rebreather mask. Same for chest pain, same for strokes, same for altered mental status, all that sort of stuff. So in reality, is there a big change? Well, the big change is one size doesn't fit all. Just like with the backboards, we want to identify the small subset of patients who actually may be hypoxic, and we want to give oxygen in a way that's consistent with their need. Either we're going to give them a lot of oxygen because they're severely injured and in shock, or we want to give them a lot of oxygen because they're fighting to breathe and they're blue and they could clearly benefit from it, or we want to use the pulse oximeter as a tool to titrate oxygen to their need. It may tell us that they don't need any, it may tell us that they need a little, it may tell us that they need a lot. One other point that I'd like to make is a pitfall of having this device is using it in lieu of taking a pulse. We really stress within OEC the value of taking a pulse, and this doesn't change that. There's a temptation to look at the reading, to look at the number and be like, I got something to write down on my piece of paper, on my report. But the issue is that you don't get the value of taking a radial pulse. To be able to judge, what's the patient's perfusion? Do they have a good blood pressure? Is that a strong pulse, or is it a really weak pulse, or is it absent? And when I take the pulse, like, is that a pale and cold and sweaty arm that I'm holding to take that pulse, or is that a nice warm pink dry arm that's reflective of a patient that has good blood flow and doesn't appear to be in shock? So all that being said, stay tuned. There's clearly going to be a lot more of this in the 6th edition, but one of the things I wanted to share with everybody is not everything in OEC has caught up to this. So please take it with a grain of salt. Anytime you read apply oxygen as needed, give oxygen via non-rebreather mask, we need to look at that in context, because oxygen is a tool just like anything else. It's not going away. We're still going to use it, but we're going to be precise about how we give it so that we maximize the benefit and minimize the risk. Thank you very much for your attention. I look forward to seeing you on the Hill.